Uh, Good morning, everyone. Today on the case project, today we'll topic with a case presentation, and today we have a special faculty from JV Pant Hospital, Professor Hriday Nag. Today, our one of our resident, Dr. Krishna, is presenting the case today. So, shall we start, sir?
Yes, yes, please go ahead.
Yes.
Good morning, sir. I'm Dr. Krishna from Mahatma Gandhi. Sir, is my presentation visible?
Yes.
Yes, I'll be starting. Yes, sir. ये काम है sir. Okay. Sir.
Yes, please.
Yes, sir. Sir, the patient is a 60-year-old housewife, a resident of Alwar, Rajasthan. She came with chief complaints of pain in the right upper abdomen for 5 to 6 months and mass in the right upper abdomen for last 3 to 4 months. The patient coming to the history of presenting illness, she started having dull aching pain starting 5 to 6 months ago, which was sudden in onset and continuous in nature, which is a non-radiating type of pain. The pain was initially mild in intensity and has over the period of last 5 to 6 months, intensity has increased. Now, since last 15 days, it is moderate in intensity, which is requiring analgesics. There is no change of nature in the pain with meals or posture. The mass in the right upper abdomen started 3 to 4 months ago, which was sudden in onset and gradually increased to a size of currently to a size of cricket ball over the last 3 to 4 months. Patient gives history of loss of appetite, unquantified weight loss over the last 6 months in the form of loosening of clothes and generalized weakness for last 1 month. However, patient is not giving any history of early satiety, nausea, vomiting, or abdominal distension, no history of jaundice or pruritus, no fever with chills, no history of hematochezia, melena, or hematemesis, no body history of bony pains. I wrote it body pain. Bony pains, recent onset of headache or seizures. She underwent open cardiac valve replacement surgery in 1984 and 2002, sir, 2 times. And right now she is on oral anticoagulants, which we don't know what medications she was taking. Also, we don't know. She do not have any other comorbidities. Personally, she is a vegetarian with sleep is normal, sleep and and regular bowel habits. No substance abuse, sir. History of substance abuse for this patient. She did not have any significant family history and obstetric history is normal, and she attained menopause 17 years ago. Summarizing, she's a 60-year-old lady who was previously operated case of cardiac valve replacement twice, presenting with progressively increasing continuous dull aching pain in the right upper abdomen for last 6 months and mass in the right upper abdomen for 3 to 4 months with loss of appetite and quantified weight loss without any history of jaundice, hematochezia, hematemesis, or melena.
What are your positive history? What is summary about just positive history?
She is having pain in the right upper abdomen and progressively increasing mass in the right upper abdomen with loss of weight and loss of appetite, sir.
Total history is 6 months.
Sir?
Total duration is 6 months.
Yes, sir. 6 months.
The 60-year-old lady with pain and say painful lump in right this thing in abdomen and
yes,
with weight loss and anorexia and weight loss.
Of appetite. Yes, sir.
Anorexia and weight loss. Then there is no other corroborative findings on history.
Yes, sir. There is no other finding of history.
Can patient tell what is the site of lump?
She was telling in the right upper abdomen. She was pointing it out.
What should you ask in these? What are the important point on history in right upper abdominal lump?
Sir, I would like to know about jaundice.
Yes.
If there is any, there is any visible lump, if it is seen, the patient is having any early satiety, multiple episodes of vomiting, or any hematemesis, or even I would like to know the history of any colicky pain if the patient is having any colicky pain of abdomen, recurrent attacks. That's also I would like to know.
What is your this thing? Means what are the possible organs or possible etiologies in that region? What comes to your
Sir,
mind?
stomach. Yes. Stomach, gallbladder, and liver.
Stomach is first,
Transfers.
right upper
No,
abdomen.
sir. No, sir. There's a gallbladder and liver. I would like
What is
first
the commonest
anatomy.
organ? What is the commonest organ from which common disease?
Sir, gallbladder.
Gallbladder and liver and
Yes,
colon.
gallbladder and liver.
Okay, then what is your differential diagnosis on the basis of history?
Sir, my provisional diagnosis is first it is a liver lesion, sir. So, looking at the history, it is most likely to be a malignant lesion. Primary site of origin most likely to be liver.
Why liver?
Sir, the patient is not having any jaundice right now. The patient is mainly giving constitutional symptoms of anorexia and weight loss. If it is had it been gallbladder, most likely by this time it would have shown in the form of jaundice.
How many
But
percent?
we cannot.
How many percentage of patient with gallbladder lump present with jaundice?
I'm not aware of the percentage, sir.
I'm right. I think it is around 50%.
Yes.
So 50% are still there will not present with jaundice.
Hmm.
So why you are not keeping gallbladder as a first diagnosis?
Sir,
ஒன்னோட issue மாதிரி இருக்கு only by
Pardon?
sir, the reason is only the jaundice part I felt about that. So jaundice, the patient
May I
is not
interrupt,
having
sir?
any jaundice.
May I interrupt?
Yes, sir.
Yeah, I'm Dr. Desai, sir.
Yes, sir.
I'm from Hyderabad,
Yes, sir.
originally from GB Pant.
Yes, sir. I know
See,
you.
yeah. See, Babu, the thing is like this. You have been given a patient with symptoms that could fit into either situation. A fundus gallbladder neoplasm need not necessarily produce jaundice.
Yes.
And once it's been pointed out to you, either you say, I don't know, but don't keep telling wrong things and trying to support wrong things. When you do that, that bugs the examiner.
Yes.
There are few cases where you will get a clear-cut history suggesting of a diagnosis. There may be some cases where you may not get that clear-cut history suggesting of one diagnosis. So you can say it is quite possible it can be a gallbladder disease also. So what is your final listing? Differential diagnosis?
Sir, I would like to first in order. I would like to place carcinoma gallbladder in the first, sir, and second HCC of liver.
Only malignant. You don't want to keep any benign condition.
No, sir.
You may be right, but you have to justify.
Yes, sir. Because of the significant features like anorexia, weight loss, loss of appetite the patient is having, along with progressively increasing mass.
So,
And at this age of 60 years, so I was
yes,
considering it
that is
to be a
also
malignant lesion.
you should mention age and other characters. How will you proceed further?
Sir, first,
Examination.
sir, I would like to examination. So next is I would like to do the general examination of the patient first.
Yes.
Shall I continue, sir?
Yes, yes, please.
Yes, sir. Coming to the general examination, patient is conscious and oriented, moderately built and nourished with ECOG of 1 and BMI of 20. She is hemodynamically stable and a breath holding time of 25 seconds. Sir. She is not having any icterus, pallor, cyanosis, clubbing, pedal edema, or any left supraclavicular lymphadenopathy, or no generalized lymphadenopathy in the patient. So I would like to go for local examinations.
Yes.
Sir, on inspection, the abdomen is scaphoid, umbilicus is inverted and pushed downwards. The right upper quadrant mass, there is a mass, spherical mass noted involving the epigastric region and the right hypochondrium, which becomes less prominent on hand and leg raising. The skin over the mass is normal without any redness. The swelling moves with respiration, sir.
Okay.
There is no scar, sinuses, or dilated veins. No visible peristalsis or pulsations. Renal angles were normal. Hernial orifices were also normal, sir. There is a no spine tenderness I have written, but it should be in palpation. Spine is non-tender. So this is the image of the patient, sir. The swelling we can see in the right hypochondrium and epigastric regions it is about.
How
Yes.
can you rule out a secondary or a hereditary cyst under such circumstances?
Based on history, sir.
Based on history, what is positive in history?
Sir, patient positively, patient is 60-year-old with progressive increasing mass in the right upper abdomen.
So why not hereditary? It's a smooth surface lump. It is in the right hypochondrium. It is
Yes, sir.
moving with the respiration. So
Yes,
why
sir.
not
Sir, but
hereditary?
but the patient is not patient is also having loss of appetite and loss of weight with anorexia, which is increasing.
Okay, that's
Yes,
Sir, I
correct.
think he has not mentioned, he has not revised diagnosis after his examination.
Yeah, please go on.
Yes. So on palpation, there is a non-tender mass with no local rise of temperature in the right upper quadrant, which is firm and the size of 10 centimeter craniocaudal and 6 centimeter in the left to right direction, involving the right hypochondrium and epigastric region. The surface is smooth, margins are ill-defined. However, the superior margin is in continuity with liver, and it moves craniocaudally with respiration, and it is a non-pulsatile mass. There is no other palpable mass in the abdomen. There is no splenomegaly.
Okay.
And spinal tenderness is also absent. On percussion, the liver dullness is noted on the mass noted, sir, which is in continuity with the liver dullness. And like we cannot insinuate the fingers also. And there is no evidence of a free fluid in the abdomen. Auscultation is normal, no bruit, sir.
What is your diagnosis now?
Sir, my diagnosis is that the mass lesion is in continuation with the liver parenchyma.
That's okay.
Sir, liver. It is most probably from the liver.
Why not gallbladder?
It still can be gallbladder also, sir. When it is infiltrating, it will become difficult to differentiate just on clinical examination, whether it is a GB mass or a liver mass.
How is the lump? It is well formed or ill defined, or it is firm or hard? What is the consistency?
Sir, it is firm lesion, sir.
Okay. How is the gallbladder usually?
Sir, gallbladder is also it is typically in a pear shape, and it can be firm to hard depending upon how tense it is.
Okay. So your diagnosis should remain same, or you want to change?
Sir, I would like to keep both as a differential diagnosis. Sir, I don't I can't confirm just on these findings at this level.
You don't want to keep any other diagnosis?
No, sir. I don't have any other thing in mind as on now, sir.
How will you differentiate from colonic mass from other masses? This thing.
Sir, depending colonic mass, sir, movement with respiration. I would like to see the movement with respiration, which is typically not there in a colonic mass, and mobility, sir.
Maybe or
whether
may
it
not.
is yes,
Maybe
maybe
if
or
it is
may not.
large, it may move with the respiration. What are the other findings?
Sir, movement, how it is moving inside the abdomen. Whether it is if it is only a transverse colon mass, it moves only craniocaudal direction. If it is an ascending colon mass, it is usually fixed. It doesn't move. If it is a locally, yes, sir. It is a dullness over the lesion and tympanic node surrounding it will be there.
Okay, how will you proceed further?
Yes, sir. Clinical exam, sir. Clinical examination. I would like to mean, per rectal examination, I would like to see if there is any bleeding or melena is there or not, and any Bloomer's shell. In this
But any
patient, they are
other
not there.
finding, positive finding, any systemic or any local finding significant other than what you mentioned?
No ascites is there, sir. In this patient, there is no ascites. Or no other palpable lumps are also there.
Okay,
Yes, sir.
you can move on.
So distal rectal examination is essentially normal, sir. Normal stools are there, no bleed or melena, no Bloomer's shell. And pervaginal examination is also normal, sir. Systemic examination is essentially normal. No added breath sounds. S1, S2, there is ejection systolic murmur. Central nervous system is also normal.
Okay.
Summarize, sir. Shall I summarize, sir?
Yes, please.
She is a 60-year-old lady who was a previously operated case of cardiac valve replacement with progressively increasing right upper abdominal pain and mass with loss of appetite and quantified weight loss without any significant family history or history suggestive of jaundice, hematochezia, hematemesis, or melena. On examination, she is a moderately nourished lady with a palpable, non-tender, firm hepatic mass, which is in continuity with the liver, without ascites, lymphadenopathy, edema, or any other palpable swellings.
Your diagnosis is same.
Sir, in order, first is carcinoma gallbladder and second hepatocellular carcinomas.
How will you proceed?
Sir, first I would like to get an yes, sir. First, I would like to get an ultrasound of abdomen done for the patient, sir. I would like to see the on ultrasound whether if it is a fundal growth which is infiltrating into the liver, or it is a liver primary, and any other secondaries in the liver are there or not, and any ascites is present or not. I would like to see an on ultrasound of abdomen.
What is the aim of any investigation? Like you are doing ultrasound, what is the aim?
Sir, I would like
Be
ultrasound.
Clear about, you should be clear about what
Yes.
you are going. Why are you doing some investigation?
Yes, sir. First of all, an ultrasound, if there are multiple liver space occupying lesions, so ultrasound itself will decide that this. I mean, ultrasound will tell that this is an
you are
advanced.
going to have a diagnosis. Okay. Whatever
Yes,
you suspected, you want to confirm your diagnosis. If you are able to with the finding, then you have to know extent of disease if possible. So
yes,
plan your management and plan your further investigations.
yes.
Okay. You just show us ultrasound findings.
Sir, she came with an ultrasound done outside. It was on 27th of Jan. It was a heterogeneous. They have just mentioned heterogeneous area in right lobe of liver of size 4 into 4.8 by 3.5 centimeters. They have no IHBRD, no other significant findings. They have not mentioned the segments are also.
This is the only positive finding. Rest is normal.
Yes, yes, sir. The patient present came to us with the outside ultrasound.
This is a single lesion.
Yes, sir.
Now what you want to do?
Sir, I would like to get blood investigations for this patient, regular blood investigations, and a CECT. Ideally, we should repeat a ultrasound again and see. But the patient already got a CT by the time she came to us.
Why do you want?
Sir, the duration is almost 5 months. It is already 5 months old. So I would like to see the growth, whether it is increased, any mets in the liver or any other organs if they are involved, and ascites.
Okay. Any finding on ultrasound that will prevent you from doing further investigations?
Metastasis and liver.
What are the conditions when you will not do further investigation in this patient, like CT, MR, or any other investigation?
Sir, gross ascites, if there is any gross ascites with the multiple liver mets.
Okay, that may be a finding. Other finding is patient is not willing for any treatment.
Okay, sir.
Even in presence of gross ascites or multiple mets, you may like to do CT scan if you are planning some treatment and to follow up to see the response of treatment. Okay, what was the CT? Can you show CT scan?
Yes, sir. Sir, this is a triple phase CECT done. Sir, there is an in the triple
You can
phase
run it
CECT.
again, that's not a problem.
Sir, we can see multiple lesions in the liver. However, there is a large lesion segment, right lobe of liver involving segment 5, 8. I can show.
Let's run this again, please. Run the CCT again.
Yes.
It's looking like it is.
This is the portal phase, sir.
In segment 4. Segment 4 and
Sir,
right.
multiple lesions. Yes, sir. No, sir. Segment 5 and segment 8. Segment 4 is also involved, sir.
Yeah.
Are they multiple
Multiple
extension of only one lesion? Because in this feed it is not clearly visible. It may be visible on films and all, but it appears it is separate, but it can be extension of same lesion also.
Sir,
Yes.
here, sorry, we can see one lesion. As you pointed out, sir, it could be an extension, but here one lesion, separate lesion, we can see.
Okay.
Can you tell whether it is showing contrast enhancement?
Sir, arterial phase, it is enhancing. However, there is no portal phase washout.
And arterial phase also is not uniformly illuminate.
Yes, sir.
Most
It
of
is
the
not
tumor is
uniform.
That
necrosis.
is not usual. It may
Necrosis.
be due to timing or it may be due to lesion characteristic.
Yeah.
So can you
It is not
define
uniform,
this?
sir.
Can you elaborate
Sir,
these findings?
Yes, sir. Sir, this is a contrast enhanced triple phase CECT in the portal venous space currently we are seeing.
Okay.
In this, there are multiple lesions, appears to be multiple lesions in the liver involving the right lobe. Here we can see one lobe of one space occupying lesion in the liver, which is heterogeneous, multiple heterogeneous lesions, sir. Again, here one lesion, and this is the mass lesion, which is involving the segment 4, 5, and 8, which is a large lesion of 10 by 6
This is
centimeters.
the prominent lesion you are saying.
Sir,
This is the prominent one, no?
Yes, sir.
Okay.
However, there is no IHBRD, sir. You can, sir.
Yes.
Sir, there is no IHBRD. However, there is no intrahepatic biliradical dilatation. I mean, the right branch of the portal vein is close to the tumor, sir. Yes, this part. It is close into the tumor, and it is being pressure is being applied on the right branch of portal vein because of the tumor. However, there is no thrombosis seen in the portal vein branches or tumor infiltration in the portal vein branches as well. There are no deposits elsewhere also seen intra-abdominally, or no ascites is seen, sir. No enlarged lymph nodes also.
Okay, what about rest of the liver?
Sir, the left lobe of liver parenchyma appears to be normal, sir. However, the right lobe, there appear to be multiple deposits, space occupying lesions. The left lobe of liver looks essentially grossly normal.
Did you say left lobe or left lateral segment?
Left lateral segment, sir.
Yeah,
left lateral segment, segment 2 and 3.
Is it of adequate volume? Is it of adequate volume?
Sir, sir, it appears that the left lateral segment has enlarged. We have not done volumetry, but appears to be adequate, sir, for the patient. Because this is all the diseased segment, which is in non-functioning diseased segment, appears to be non-functioning diseased segment.
What is the build of the patient? Is she hefty and large, or is she small?
No, sir, she is moderately built. She is small and less weight, sir. 144 centimeter height and 44 kilos of weight.
So what relation that has with the remnant volume?
Dr. Krishna, what is your diagnosis
Sir,
now? What is the lesion?
Yes, sir.
This is from liver. So what is that mass with CT characteristics and history you told?
Sir, sorry, sir, I couldn't hear you.
What is your diagnosis now?
Sir, this is CT scan has shown multiple space occupying lesions in the liver, sir. Probably it is a multicentric HCC or a metastasis from elsewhere.
Okay. So how will you
Yes.
confirm now? How will you confirm?
Sir,
Suppose your two diagnoses, metastatic and this thing, primary.
yes.
So how will you
Sir,
confirm
ideally,
this primary or metastatic?
sir, ideally we should get a biopsy done with a IHC. So if it is multicentric HCC, then we will know, or metastatic disease.
Do we get in every HCC? Do we get FNAC or biopsy?
No, sir. HCC, there is no need. The doubt of HCC is very less in this patient because of the characteristic CT finding of no portal vein washout.
What is
in this
other?
patient.
No portal vein washout. What is that's what I want to know. How will you confirm? Is there any blood investigation that can indicate?
Yes, sir. We have, yes, sir. We have got blood investigations done, sir. The patient is having HB on the lower side of with 9.7 with increased serum CEA, sir. CEA is 185. However, A alpha fetoprotein is within the normal limits, and beta HCG is 4.5, which was done outside. They have doubt of any ovarian pathology which is causing metastasis, so they got it done outside like this. So it is suggesting that it is some colonic pathology causing multiple liver mets, depending on the blood investigations.
Okay, what is CT scan report? Was the final CT scan report given by radiologist?
Yes. They have shown ill-defined heterogeneous lesions involving 4, 5, and 8 of liver with mild heterogeneous enhancement in arterial phase, which persists in portal and venous phases. Few similar lesions noted in the surrounding liver. The right branch of portal vein was compressed with the lesion, size of 94 by 78 by 118 mm. They have given very multiple metastasis. However, atypical HCC and fibrolamellar HCC cannot be ruled out. They have not commented about any other.
Okay, you have got blood investigation, you have a CT investigation that is suggestive of metastatic lesion or HCC. Okay.
Sir, it is suggestive of both CT and blood investigations. They suggest that it is a metastatic disease.
Okay, you want to believe it is metastatic, then what will you do further?
Sir, ideally, we should get a colonoscopy done in this patient. The thorough colonic evaluation should be done in the patient first to see whether it is a colonic lesion, and fecal occult blood test.
Okay, you did colonoscopy?
Sir, the patient didn't get any colonoscopies. The patient was evaluated in form of PET CT.
Okay, what was the in PET CT?
Yes. So PET CT was done, which had shown a heterogeneous enhancing asymmetric circumferential wall thickening in the ascending colon for a length of approximately 3 to 3.5 centimeters. The maximum thickness is 1.7 centimeters with SUV max of 6.71 centimeters, involving the distal ascending colon with no significant luminal narrowing and mild. It is having mild perilesional fat and soft tissue stranding. Liver is enlarged with FDG EBIT heterogeneously enhancing soft tissue mass lesion in right lobe, measuring 8.5 by 9.4 by 10 centimeters with SUV of 14.7. Multiple discrete small hypotenuse lesions in the right lobe of liver, measuring 2 by 2.1 centimeters. Largest lesion is compressing the right branch of portal vein without infiltration.
So there is a colonic lesion and with the liver lesions. Okay?
Yes, sir.
So your final diagnosis is CA colon metastasis.
Yes, sir. CA colon with liver metastasis, multiple liver mets.
What is your further plan?
Sir, first I would like to go for a colonoscopic guided colonoscopy and biopsy. to see the type of the lesion, and then the patient for neoadjuvant chemotherapy, sir. And once the sir, currently the patient is not having any obstructive symptoms or any, even though the HB is on the lower side, grossly the patient is not having any bleeding findings. Fecal occult blood test is awaited. So there is right now there is no need to go for any hemicolectomy right now. So first we will go for neoadjuvant. Currently the plan is to go for neoadjuvant chemotherapy, sir. After that we will see for resolution of the lesions in the liver. If the lesions are reduced in size and no additional lesions in the left lobe of liver, no progression of the disease, then the plan is to go for extended right hepatectomy with extended right hemicolectomy, sir. Current plan. Before that, we would like to go for portal vein, right branch of portal vein embolization, so that we will induce hypertrophy in the left lobe of liver.
Did you review the CT scan? It is unlikely, no? There was a lesion, it is seen in FDG PET and this is not visible on CT. Was it missed or was it not visible?
CT, so the first CT, what was done, the patient has not got, the patient had not got, contrast in the colon, sir. They have not given. So, and there is a lot of feces also. So probably that could be the reason why the lesion was missed in the CT scan.
Okay. There is no need to give contrast on colon to look for the lesions in the colon. Maybe contrast quality was not poor or it was not suspected and is not followed up properly. That may be a reason. Okay, so you want to do colonoscopic biopsy. Why not FNAC from liver lesion or both?
Yes, sir. Both. We can get done both, sir. We can get both of them.
What is the benefit or advantages and disadvantages of doing both or doing single?
Sir, the disadvantage of doing FNAC from liver is that we may induce tumor seeding. Second, can bleed also. Procedure related bleeding.
How is it going to change management? Your tumor seeding is going to affect if it is metastatic lesion.
Yeah, sir. We till now have a plan of hepatectomy. Like we don't want the
Patient
stage.
already has got metastatic disease. If it is,
yes, sir.
Believe it is from colon and it is metastatic, is already metastasized. Remote possibility, maybe it is other lesion.
Another lesion, remote possibility, yes.
Maybe atypical HCC. Yes,
sir.
In my opinion, I'll do both FNAC also and I'll do the.
Okay.
Suppose this is both, it is metastatic. We
yes,
have
sir.
done both, it is adeno there, it is adeno there, both are adenocarcinomas. Did you do the biopsy? You have biopsy?
From the liver lesion, sir.
No, any biopsy report. Colon.
Yes, sir. I get a colonoscopic biopsy.
Yes, you just show us.
Sir, it is not yet done, sir.
You are planning to. Suppose it is adenocarcinoma.
Yes, sir.
You have done it is both. It is metastatic adenocarcinoma in liver, suspicious of metastatic adenocarcinoma, and there is adenocarcinoma. So what is your plan for this?
Sir, right now is neoadjuvant chemotherapy. We will send the patient for neoadjuvant chemotherapy. And along with that, we will go for right portal vein branch embolization.
So we will embolize the right portal vein and send it for chemotherapy.
No, sir. First, we will give for chemotherapy, and later we will go for any if needed embolization. Then later stage. First is chemotherapy.
Do you want to embolize something other than the right branch of the portal vein? The liver is occupied by tumor, so don't expect much results. So based on that, do you want to add something on?
No, sir. I am not
Want
sure.
to embolize the segment 4 venous branch?
Yes, sir. Segment 4 also should be done.
Yeah. And what is the place of Alps in a patient like this?
Sir, I'm not sure, but like I'm not sure, sir. Right, portal vein
Okay,
embolization is
generally the risk would be too high. Alps is being done in few centers, and they're suggesting that if you do a 2 to 3 centimeter section of the liver and do portal vein ligation or embolization, it is producing hypertrophy of the remnant.
left lobe of left lateral segment.
Yeah, I think it looks
Uh,
small.
Yes.
So will you suppose you have done this thing? Neoadjuvant, there is a significant response.
Yes, sir.
Then how will you significant response on liver lesion?
Yes. So again, sir, I would like to, we would left lobe, we would see whether the left lobe is enlarged or not. How is the left lobe and assess the volume, and then we would go for extended right hepatectomy and second plus extended right hemicolectomy, sir, in this patient.
So you want to do it both on same sitting, or you want to do in two sittings?
Sir, both on same sitting. If the patient is depending upon the general condition of the patient at that time. Like right now, the patient is can tolerate the physically fit, sir. She can tolerate. So we can go ahead with both procedures on same sittings.
There is some liver first approach. What is that?
Yes, sir. Liver first approach and colon first approach. There are two separate approaches. Where
Yes.
first the primary is the primary is tackled first and metastasis later, or first the metastasis in the liver first approach, only the mets are tackled first, then the primary is tackled later after if in the case of cerectomy or chemoradiotherapy, like that.
What are the advantages and disadvantages of both? Is there any?
So the disadvantages of liver first approach, sir, because the primary is still present, the patient can still have a tumor emboli into the liver during the course of the treatment. That is one disadvantage in this patient. If it is only if we go for the tumor first approach and liver later, and then there is a chance that two chances are there. One, the problem of disappearing mets is one problem. And seconds are in still the lesions which were there, they can also increase in size. That's also one problem.
We can open this topic for the discussion to all. If anybody asks some question, want to ask some question or suggestion, then we can do that.
See, you're planning to do a extended right hepatectomy.
Yes, sir.
Remnant is doubtful. And what are the disadvantages of chemotherapy on the normal liver? If you're using irinotecan, you'll get fatty liver. If you use oxaliplatin, you will get sinus involvement. So, would you prefer to give chemotherapy when the remnant itself is doubtful? Won't that increase the amount of FLR required?
Sir, it actually chemotherapy definitely induces associated steatohepatitis, but the right lobe of liver is predominantly replaced by the non-functional tumor in the right lobe of liver, leaving only small quantity of the normal parenchyma there, sir. So we are expecting that in the functional liver parenchyma, the left lobe is constituting 50 or more. So we were thinking even after chemotherapy, the patient will have at least the required volume of the normal functioning parenchyma will be present. This is what we are thinking, sir.
Okay. Would you do a liver biopsy?
Sir,
Would you do a normal liver biopsy, not the tumor? Would you biopsy the normal liver? What are the indications for that?
sir, if we have doubt of liver cirrhosis or any fatty liver, the quality of the liver, then we have to
Okay.
get a biopsy, sir.
Sure.
What is the mechanism of hypertrophy induced by the distinct portal vein embolization?
So the portal vein embolization of the C1 branch will induce increased flow in the opposite lobe, non-obstructed lobe, which they say that the pressure induces the capillaries in the liver to distend, and it stimulates the liver parenchyma to grow. So this is the theory, sir.
Induces growth factors.
Yes, growth factors.
Stimulate generation of growth factors, and that causes the growth of liver. What is the
Yes, sir.
disadvantage? Is the tumor also grows sometimes,
Okay, sir.
because these growth factors will affect the tumor. Sometimes outgrow normal liver. That is the drawback also. What is the usual time when you reassess the FLR after giving what? Yeah, what is the usual time when you will take up patient after portal vein embolization for surgery?
Sir,
Usual scenario.
Sir, starting from second week itself, we can see the growth, volume growth we can see from second week itself, sir. By 4th to 6 weeks, the maximal growth will be achieved.
Suppose this patient PET CT was, there is no other lesion, colonoscopy was normal.
Colonoscopy was normal, yes, sir. Okay.
Colonoscopy was normal and there is no other lesion and PET CT, only liver lesion is. What is your approach?
Yes, sir. So I would like to go for a biopsy or transhepatic biopsy of the lesion and with immunohistochemistry, sir.
Okay. Suppose it is HCC, then what is your system?
So if it is HCC, it is a multicentric HCC, so only medical line of management. It is an advanced disease and it will become in a medical line of management in this patient, specifically in these patients.
Why? Right liver, left liver is there.
Sir, but these things are, multiple space occupying lesions are there, multicentric HCCs. Ideally, we should go for the biopsy of the
this is on the same lobe of liver. Nothing
Yes,
is preventing resection with proper planning. Prognosis may be poor. Prognosis may be poor. That is, you are right, multicentric hai ye, but it is amenable to resection with proper planning. If it is amenable to resection, you should go ahead with the resection. What are the treatment for this thing? One is the resection, other is the transplant. Is this a candidate for transplant? If it is HCC?
So even if it is HCC, we would like to see whether the AFP should be less than 400 and no distant metastasis should be there. In such scenarios, we can plan for transplants. Multicentric, I'm not sure.
You can extend the criteria that can feasible, but usually it will not be fit for cadaveric transplant. It may qualify for living related. Okay. Extended criteria and all preparation, but usually these are candidates are not for fit for this thing. Usually they are fit for the resection or for the palliative or palliation or this thing, chemotherapy. You may try chemoembolization and other things also.
Yes.
Such patients. I think we can stop now if no further questions.
Thank you, Nag sir.
Yes.
Regarding this patient, sir, one or two questions.
Okay.
Like this patient is having a large lesion in the right lobe of liver and ascending colon mass. So as we know, the primary is asymptomatic and patient is having liver mets. So plan is to give a neoadjuvant chemotherapy. Then probably we'll assess this patient with the help of PET after the completion of this chemotherapy to know the mets in another part of liver or the mets at a distant area like liver mets, like lung mets or the peritoneal disease. If the patient is not having mets other than the liver, then we can go for this volumetry of the liver, and after we have two approaches: liver first or the primary first. So,
Okay.
in your experience, what do you do, like liver first approach or primary first approach? If the disease having resectable disease resectable.
Actually, depend on the presentation also. If it is there is no compelling reason, there is no symptom to palliate like bleeding or obstruction, then we follow the approach you are saying. Okay, we'll send for the chemotherapy and then reassess the patient with this thing, and then most likely we go with the this thing, same setting, we do both this thing. In some cases, we may like to resect liver first and then we will go for the colon.
Okay, sir. Thank you, sir. And
Thanks.
thank you, Nag sir. Thank you, Rajendra sir, for moderating the today's session. Thank you. We can
Thanks.
close the session.
Thanks.